The views expressed on Skeptically Speaking are not necessarily the views of this station, its affiliates, sponsors, or advertisers.
Bring it on, the skeptics await your letter. Your call, tweet, homing, pigeon, whatever. Desiree Shell gonna raise a little hell, metaphorically that is, cause we're skeptically speaking.
Hello and welcome to Skeptically Speaking. I'm your host, Desiree Shell. This week, we're focusing on the health of the splendid and mysterious organ that makes everything we think of as human happen. I'm talking, of course, about the brain. A little later, we'll speak to Harvard researcher Richard J. McNally about his new book, What is Mental Illness? But first, let's learn about antidepressant medications. Thanks for listening. I'm here with Maia Szalavitz, a neuroscience journalist obsessed with addiction, love, evidence-based living, empathy, fertility, and pretty much everything related to brain and behavior. She's the author of Born for Love, Why Empathy is Essential and Endangered, and her work has been published in, among others, Time Magazine, New Scientist, and Psychology Today. She's also the winner of the American Psychological Association's Division 50 Award for contributions to the addictions. Welcome to the show, Maia.
Oh, thank you so much for having me.
So what are antidepressants exactly?
Well, that's an interesting question. They act on a variety of different neurotransmitters, and they do seem to lift depression for an awful lot of people in an awful lot of clinical trials. The problem that comes up with some of the research is that some of it does not distinguish the drugs very clearly from placebo. And there's been a big debate about this lately, but one of the things I think is going on there is that if you look at individual responses to antidepressants, they are hugely varied.
Are we talking about a specific type of antidepressant? Because there are a few different classifications.
Yes, that is true. The critiques have been mostly of the selective serotonin drugs and the other newer antidepressants, some of which act on dopamine and some of which also act on noradrenaline. But the debate has centered on these newer ones, and the idea is just that they are basically expensive placebos. The problem with that position is that in the data, if you sort of dig down into it, you will see that some people are made spectacularly better, some people are made spectacularly worse to the point that they may be suicidal or even homicidal. And if you do that by numbers, it looks like nothing happened because it cancels each other out.
Right.
It's very sexy to say, oh, it's all placebo and they're all making it up and, you know, it's just evil drug company hype. And the reality is there's tons of evil drug company hype, but antidepressants also do work.
Okay, let's go back a bit. Can you tell me exactly how a selective serotonin reuptake inhibitor works?
Well, nobody really knows, to be honest.
Right.
The previous theory was that by elevating levels of serotonin, the drugs lift depression. The problem with that theory is that these drugs elevate serotonin very rapidly, but they take about 2 weeks to lift depression. So how can that be if that's the mechanism of action? There's a newer theory which also has problems, but may account for some things, which is most of the antidepressants do seem to, in about 2 weeks, increase nerve growth in certain areas of the brain. So people have said, aha, that's why it takes 2 weeks, because it takes 2 weeks to grow nerve cells. The problem with that is that ketamine lifts depression within a couple of hours, which is way too fast for nerve cells to grow. So it's kind of back to the drawing board on that. But, you know, something is clearly wrong in the brains of depressed people, and there's lots of imaging data and other stuff that suggests serious problems there.
Okay, now you were just talking about neurogenesis. So what makes people think that antidepressants encourage neurogenesis?
Well, they are shown to raise levels of a chemical called BDNF, which is brain-derived neurotrophic factor, and it helps nerve cells grow. There's also some interesting evidence that when people recover from depression, by no matter what means they recover, they do show increased growth of nerve cells in the hippocampus. And that's especially interesting because when people are under high chronic stress, especially uncontrollable stress for a long period of time, it actually damages the hippocampus. So this makes a nice little theory where that damages it and this fixes it.
So now again, is that only a certain type of antidepressant or which kind?
No,
is that?
Anything that works seems to do that. nobody really knows the mechanism, and again, it's really messy because there's probably multiple forms of depression and probably multiple pathways to it. Some people may get there via, having been abused as a child. Some people may get there via some genetic vulnerability. There's probably all kinds of combinations of the two. There's epigenetics. It's really extraordinarily complicated. But it does seem to be the case that when people get better, their brains grow a little bit. And interestingly, antidepressants also seem, particularly I believe the SSRIs, also seem to help people recover from stroke and from other forms of brain injury, suggesting again that nerve growth is important to their mechanism of action.
I find this really interesting. There's so much controversy around antidepressants to begin with, but why is it so difficult to find out how they work?
Well, the brain is extraordinarily complicated, and the reality is that these drugs do many different things. So the SSRIs raise serotonin, bupropion, which is called Wellbutrin, raises dopamine. Some of the others affect noradrenaline. So it's really complicated, and I've only mentioned the classic neurotransmitters. We now know that there are 50 or 60 different neurotransmitters with weird names like ghrelin and all kinds of other things, not to mention the fact that we now know of 5 or 10 different receptors for each transmitter. And there are multiple different systems, and there's multiple brain regions, and there's the immune system throwing in there. So the brain is extremely, extremely complicated, and it's not surprising that we haven't worked out an exact mechanism of how these work. The good thing is, though, that something like 80% of people can get significant relief from something at this point, and depression is truly a crushing, horrible condition. I personally have suffered from it, and I know that there comes a time when you feel like you cannot experience pleasure at all, and it is crushing to live that way.
You're listening to Skeptically Speaking. I'm talking with neuroscience journalist Maia Szalavitz about antidepressant medication. So you just mentioned effectiveness. Now, how effective are they then? You said 80% of people.
Well, can ultimately find something. Probably on your first go, 30% of people are going to get better. And, we then have the question of how chronic is your depression, how severe is your depression. The worse your depression, the more likely the drugs are to help, which is a good thing. And there's also obviously a whole range of talk therapies that seem to be very helpful. In my experience, a combination is better, and there are certain things that only a drug can touch.
For example?
That anhedonia, the pleasurelessness. If you are feeling so that you dread seeing people, and so that, even getting out the door is a massive amount of effort, it doesn't matter how many times you tell yourself, I'll feel better when I get out the door. If you don't actually feel better when you get out the door, if you end up feeling worse, there's nothing you can do to talk yourself into feeling better. If the chemicals just aren't there to make you feel better, you just aren't going to feel better. And, that's when, for me, I've found anyway, that antidepressants are really the only thing that helps. That's obviously anecdotal experience, but clinically, I've talked to, lots of psychiatrists, lots of researchers, many people who have looked at this in many different ways, and they tend to say some version of that when your depression is severe enough. Just nothing else really, maybe ECT, but other than that, there really isn't much else.
Now, one of the things that I've heard recently is the idea that clinicians do say that antidepressants work, and they can speak to how well they work with their own patients. But if the clinician has never been a part of the clinical testing process and hasn't seen, I guess, the kinds of improvements that a placebo group would experience, they don't really necessarily have the best basis for comparison. What's your opinion on that?
Well, everybody can't be in a clinical trial, for one.
Right.
And I'll just put it this way. When you talk to people who've run clinical trials and they talk about, the sort of classic Peter Kramer listening to Prozac experience that some of their patients have, where they are literally transformed, and then some of them, go screaming into the night from, akathisia, which is this horrible sense of, that you are unbelievably restless and incredibly uncomfortable and want to kill yourself or somebody else. Those two people are having really opposite responses. but you're putting them into, number scores. And so when one of them's going up and the other one's going down, you can end up looking like it was placebo. But if you look at the individual patient's responses in the trial, you will see an enormous variation. And that's not surprising given the enormous variation in human genetics, particularly of these receptors that are involved in the way these drugs work. And there's another aspect to that, which is liver enzymes make the metabolism of these substances very, very, very varied. So you may have a liver enzyme that makes it the case that if you take the opioid codeine, it won't work at all because that has to be broken down into morphine in order to be effective. And if you don't have a liver enzyme that does that, it'll just pass through your body and it will be as if you took a placebo. So when you throw the brain variation and the liver variation together, and there's probably all kinds of other variation that hasn't even been discovered, the fact that some people are getting huge responses and some people are getting no responses and a lot of people are getting slight responses isn't surprising. I was talking to an opiate researcher, speaking of opiates, who said that in a lot of clinical trials of opiates, they don't come out better than placebo. We all know that opiates work better than placebo. And interestingly, it does seem like opiate effects are actually behind a lot of placebo response, which is even more interesting. So if you tell somebody you're going to give them a painkiller and then you give them a painful experience, they will have less pain than if you tell them you're going to give them something that will make the pain worse, even when you give them exactly the same drug.
Oh,
and
our
if you
brains.
give them, it's really amazing. And if you give people an opioid and tell them it's not going to work, it will be less effective. What's really mind-blowing is, though, that if you give people a placebo versus aspirin, they'll have half the response with the placebo. But if you give them a placebo versus morphine, they'll have half the response to that, which is more than the response to aspirin. So nobody knows how this stuff works. It's really, really complicated, and sort of teasing out the little bits of it is a very difficult thing to do.
Definitely. Is there, I guess, a reasonable scientific consensus on the effectiveness of antidepressants? Because I'm always wondering if these kind of controversies are actual scientific controversies or if they're mainly media-driven. And I blame the manufactured climate change controversy for everything, honestly.
Well, I mean, there are several problems going on here. One is the fact that the drug companies demonstrably lie about things.
Right.
So people don't trust them. They hide data. They obscure data. They do all kinds of things that they really shouldn't do because they actually do have some good products that really work. Mm-hmm. So that makes it very difficult. The other thing that makes it very difficult is that, there's no test for depression. There's no depressionometer. And we can't, say by a brain scan or by, some other so-called objective measure, this one's depressed and this one isn't. So, it looks very nebulous and socially constructed. And the reality is, of course, that cultures do experience depression differently. So in different cultures, people do have slightly different symptoms. But depression is something that has been reported since the Bible. There are some commonalities that are seen cross cultures, cross time. The anatomy of melancholy,
right.
People have recognized this condition for a really long time. Postpartum depression has been recognized for a really long time. So there's a biological thing going on there too. Just because we can't put our finger on what the biology is yet doesn't mean that it's not a real condition. And anybody I know that ever has met somebody who's been profoundly depressed, you can tell depression just listening to somebody's voice a lot of the time. You can see it in how they move. It's not something that is kind of obscure.
Right.
People can successfully hide it sometimes, but when somebody is profoundly depressed, it's painful almost to look at them.
You can find Maia Szalavitz, neuroscience journalist and author of Born for Love, Why Empathy is Essential and Endangered, at the link on our website at skepticallyspeaking.com. And we'll be right back to speak to Richard J. McNally, author of the book, What is Mental Illness?, after this.
Skeptically Speaking wants you to question everything. To be a part of the discussion, call and record your question on our listener question line at Speak 73101. That's 773-257-3101. Long-distance charges may apply. Sunday nights at 6 Mountain Time, join our Ustream chat room to listen and ask questions as we record interviews live. Just click the Listen Online button at skepticallyspeaking.com. You can also email your questions and comments to live@skepticallyspeaking.com, or if you're on Twitter, tweet us at Skeptical Radio. To find out where Skeptically Speaking airs near you, to listen to past episodes, or download the weekly podcast, check out our website at skepticallyspeaking.com. While you're there, follow the links to connect with us on our Facebook page, our Twitter feed, or to subscribe to the show in iTunes. And now, back to the show.
My guest today is Richard J. McNally, a licensed clinical psychologist and the professor and director of clinical training in the Department of Psychology at Harvard University. He's also the author of the new book, What is Mental Illness? Welcome to the show, Richard.
Thank you for having me.
So let's set the stage here. I would like some stats. What's the percentage of the population that's actually dealing with mental health issues?
The best estimate is about half of the population has qualified for a mental disorder at some point in their lives, and about 25% of the people in the United States, adults, have qualified for a mental disorder in the previous 12 months.
So where are we getting those numbers?
The numbers come from the National Comorbidity Study, Revised. It's a large survey based on random samples of American adults that was run by Ron Kessler, actually a colleague of mine over at Harvard Medical School. Kessler used the latest diagnostic criteria, using structured interviews, the best methods that we have available, and these are the numbers he came up with.
Well, let's talk a bit about the Diagnostic and Statistical Manual for Mental Disorders, also known as the DSM. Tell us about that book. What's its history?
The DSM first appeared in 1952. We now call it DSM-1. That was the first edition. And nobody really cared very much about diagnostic issues back in the 1950s. First of all, that was the heyday of psychoanalysis. If everyone who came in for treatment got more or less the same intervention, some sort of psychoanalytically based therapy, well, then whether or not they had one disorder versus another disorder was immaterial. This later changed once the psychopharmacologic revolution occurred, where you had, for example, some medications were more effective for people with schizophrenia, other medications more effective for people with manic depressive illness, now called bipolar disorder. And once you have different types of treatments that work for one type of disorder but not so well for the other, and vice versa, then suddenly getting the diagnosis correct matters. And so greater attention then began to be drawn to this. In 1968, the second version came out, but this version really wasn't very much of an improvement in some ways, because the disorders were described in very sort of impressionistic ways. And some very embarrassing studies appeared on the scene where, for example, you would have videotapes of doctors in America interviewing patients with paranoid schizophrenia, for example, and then British doctors using the same videotapes that say, oh, this person has bipolar disorder. And so the reliability, the degree to which different interviewers interviewing the same patient agreed was abysmal. And if you can't agree on what disorder the person has, you're in trouble.
Right. So what's the process here? How does something become a DSM-defined disorder?
Well, what happened with the DSM is that the manual really became quite important in the late 1970s. And a group of gay activists were complaining that homosexuality was a mental disorder in DSM-2, and they said, there's nothing wrong with us, we're perfectly happy with our sexual orientation, et cetera, and they were protesting at meetings of the American Psychiatric Association, the APA, and other venues, demanding that it be removed. And they challenged the psychiatric establishment to say, what do you mean by mental disorder? You have to get clear about these sorts of things. And to make a long story short, in DSM-3, which appeared in 1980, it completely revolutionized the field. Mental disorders were now defined explicitly by their signs and symptoms. And so there are objective criteria. And the idea here is if you really pay attention to what the patient is saying, what the patient is doing, rather than making inferences about his unconscious mind, for example, as the psychoanalytic tradition always did, then maybe we can agree on whether someone has this disorder versus that disorder. And so from 1980 onward, we have an entirely different system that's based on these objective criteria. And this, in turn, has fostered a lot of research on what works, what are the causes of mental disorders, and how best to treat them. And that research then has sort of fed back into the field and then shaped the sorts of conditions that have been included in subsequent editions of the DSM.
Well, that's a fairly stark change in something that was included in the DSM. Are there other examples that are that controversial?
There have been, for example, some very interesting ones that were removed. My favorite one from DSM-2 was the diagnosis of inadequate personality disorder.
Right.
So you can sort of imagine giving this diagnosis. The patient says, "Doctor, what is my diagnosis?" And you say, "You have inadequate personality disorder." Well, the description of this was as follows. I'll simply quote it, and you can sort of get an idea. This is just how vague things were. It was, quote, "This behavior pattern is characterized by ineffectual responses to emotional, social, intellectual, and physical demands. While the patient seems neither physically nor mentally deficient, he does manifest inadaptability, ineptness, poor judgment, social instability, and lack of physical and emotional stamina." Now, how can anyone tell whether someone qualifies or not? All of those terms are so vague, so open to interpretation. And this disorder died of its own terminal vagueness, and nobody tried to re-describe this in objective terms. It just wound up in the ash heap of psychiatric history, so to speak. But other types of conditions, for example, panic disorder, appeared for the first time in the DSM-3. Clinical researchers had identified people who had these sudden rushes of intense terror that seemed to come out of the blue for no apparent reason. And these types of intense attacks of terror seem quite different from ordinary anxiety or chronic worry and things of that sort. And so the research then provided the basis for this new syndrome, panic disorder, that appeared for the first time in the DSM-3. So you see, some conditions disappeared, others were redefined, and others appeared de novo for the first time in DSM-3.
We have a question from the chat room. It's from Cy Curious.
How do you think the explicit definition of psychiatric diseases has affected the stigma of mental disorders that exists in society?
Yeah, that's an interesting question. I think that largely the question of stigma turns on treatability. I think that once disorders become treatable, they become less frightening to not only the people who suffer from them, but also to other people. And once data, such as the National Comorbidity Study, appear showing that these things are actually fairly common, and that many people do suffer from these, and they're treatable, these sorts of things tend to lose their stigma to some degree. So the explicit definitions of mental disorders that appeared for the first time in DSM-3 fostered the type of research that led to discoveries of effective treatments, which in turn fed back and reduced stigma.
You're listening to Skeptically Speaking. My guest today is Richard J. McNally, professor and director of clinical training in the Department of Psychology at Harvard University. Well, let's look at one of the major disorders, major depressive disorder. Now, to be diagnosed with that, according to the DSM, a person must experience either sadness or a loss of pleasure for most of the day for at least 2 weeks, in addition to 4 other symptoms like sleep disturbances, fatigue, or concentration problems. So would that be considered abnormal then? And you cannot see my air quotes.
Well, this really gets at the boundary problem. Where do we draw the distinction between psychological distress and psychological disorder? And major depressive disorder has been a real flashpoint for discussions along this line. So, for example, a person might very well experience fatigue and loss of interest and things of that sort for a variety of different reasons, and yet there may not really be any fundamental dysfunction in the person's brain that is the source of these symptoms. It may be simply reflecting the ups and downs of everyday life, ordinary stress. We're not evolved, so to speak, to be constantly happy, and departures from perfect happiness, should we really be calling them mental disorders.
Right.
And so one question here has been, is the threshold for identifying someone with major depressive disorder set a bit too low? Are we having so-called false positives, individuals whose distressing symptoms arise from rather benign sources rather than something more serious that will progress to a very, very serious, potentially life-threatening condition? That's one argument.
Is it possible to quantify the difference between normal distress and a mental health disorder at this point?
Well, you certainly can measure that. So, for example, a person who has the full range of symptoms of major depression and has had it for months or perhaps even years and is suffering a significant impairment, those cases are the easy ones. I mean, it's a clear disorder. It's the cases at the boundary where things really get fuzzy. So there's no bright line that separates psychological distress from psychological disorder.
But you do say that major depressive disorders are increasing over each successive generation. So where does that information come from?
Well, that actually comes from a number of different surveys where, for example, people who are in older cohorts, so they were interviewed and then asked to think back, well, had you ever met any of these symptoms, et cetera, et cetera. So, for example, people who were born in the 1920s and 1930s, the proportion of those individuals is smaller who qualified for major depression relative to the baby boomers, relative to the Generation Xers. When people wonder, well, what does this mean? Are there changes in society, for example, over the course of the 20th century and into the 21st that has rendered people more vulnerable to suffering major depression? Or do people in older generations maybe they've simply forgotten
right.
what they had these things? And then, of course, there's always the sad possibilities that individuals who did have major depression in earlier cohorts have died, because serious major depression impairs immune function, cardiac function, and of course, there's the risk of suicide. But so there's probably several of these things going on. But there are also factors in modern society, the disconnection among people, psychosocial stressors, economic stressors that are making it perhaps more difficult for people to get on today, and the later cohorts being somewhat more vulnerable.
Well, you also say that mental disorders are being diagnosed at younger ages as well.
Yeah, that's definitely true as well. And in fact, one of the things that is quite striking about, say, the National Comorbidity Study are the large number of individuals who had mental disorders, say, before the age of 14 or so. So, for example, I've worked in the area of anxiety disorders for a long period of time, and I treated with behavior therapy many patients with obsessive-compulsive disorder. Most of my patients were adults, and we've always considered OCD as being an adult anxiety disorder. Mm-hmm. And lo and behold, the more we study these things, we find that many of these individuals began having symptoms. They may have concealed them, not complained of them, and so forth in childhood. And so a lot of these mental disorders begin early in life, in the elementary school period, in junior high school and the like. And so I think that's at least partly a matter of detection. I think we're more aware of these things than we once were.
It could also be that just more people are seeking help for mental health issues. Because we spoke about stigma. I assume that there's less stigma around pursuing psychiatric help now than there was in, let's say, the 50s.
Oh, I certainly think so. And there's been, of course, a lot of consciousness raising and so forth about this, and that certainly has helped. But the epidemiology studies, such as the National Comorbidity Study, the Epidemiologic Catchment Area Survey, and so forth, these surveys were done on people in the community. And so the issue of stigma plays less of a role. So, for example, if you were simply to base your estimates on how common, how prevalent certain mental disorders are based on the people who are coming for help, then I think you're absolutely right. You're going to find this increase that's largely attributable to people seeking help, feeling less stigmatized, knowing help is available, knowing help works. But in the epidemiology studies, the researchers go out into the community. So regardless of whether someone's seeking help, they are diagnosing the disorders at higher rates. And a lot of these people aren't seeking help. And so this would seem to suggest that there's actually a genuine increase in the community, regardless of whether someone's seeking help or not.
Well, we have another question from the chat from Baitor.
Are the increases in diagnoses explained by changing definitions of the disorders, or is it due to a better ability to detect them, like with autism?
I think both of these factors play a role. For example, with autism and with social anxiety disorder, The definitions are broader than they once were. With autism, for example, back in the 1980s, I had done some work with autistic patients, most of whom the classic cases were mentally retarded. They were very, very severely impaired. Few of them had possessed language. Many were institutionalized and so forth. And that was sort of the classic autistic case. And then we have this autistic spectrum condition, whereby people who are often of normal intelligence, possess language and so forth, but have some of the impairments in a much milder form. So the concept has broadened, and unsurprisingly, the number of people who qualify for a broadened concept goes up. Same with social anxiety disorder. In 1980, the idea here was that a person had a very specific, as it was called then, social phobia, a very severe fear of speaking in public, or fear of eating in public, or signing one's name in public, like signing a checkbook, because your hand might shake and the person might notice it and you'd be mortified by that. But then researchers noticed that, well, the people just don't have these very specific phobias, but it's a more general sort of fears of social interaction and being evaluated. And then it starts to blend into shyness. Again, encounter this boundary problem. And so suddenly you find much higher rates of social anxiety disorder, a condition that's not confined to just these very specific conditions, situations when they can't do certain things. When you broaden the definition of a disorder, you will find higher rates of it.
So are all the mental disorders on the increase?
It's a good question. Some of them have increased more than others. Schizophrenia has stayed fairly stable. The diagnostic criteria become more clear, more specific than they were, say, under DSM-2, but it's not as if it's been broadened considerably in such a way. So the prevalence of that is usually, lifetime prevalence is about 1%, give or take a bit, around the globe. And so that one really hasn't changed that much. But social anxiety disorder is far more common.
By any chance, is there a decrease in any of the disorders?
Well, one that does seem to be decreasing right now is dissociative identity disorder, what used to be called multiple personality disorder. And here you've got a very, very interesting case where you have this condition that made its way into the DSM-3, and suddenly it skyrocketed.
Right.
This incredible number of cases being diagnosed by a relatively small handful of clinicians around the United States and Canada and in the Netherlands. And a lot of the people who are diagnosed with MPD, they would come in for various problems, marital problems, maybe chronic mild depression, things of this sort. And suddenly, during the course of therapy, these personalities would emerge. And the person got the diagnosis of MPD. Now, this disorder appears to have almost disappeared in the last 10 years. And this was, of course, all tied up with the debate over so-called repressed and recovered memories of traumatic events, because the prevailing theory was that people who had been exposed to horrific childhood physical and sexual abuse tended to have a personality that fragmented and broke off and dissociated. And so these new personalities would develop that would be receptacles for horrific memories that the person's main personality could not countenance. And so these were sort of repressed or dissociated and blocked off and so on and so forth. And the task of the therapist was to help the person recover these repressed or dissociated memories of trauma. They process them, have all this intense emotional affect, and eventually the personality would be sort of sewed back together. That was the idea. Well, a lot of people didn't get better. They just got worse. And the whole controversy over using hypnosis to help recover these memories and so forth became a rather discredited process. And suddenly, as that therapeutic technique vanished from the landscape of psychiatry, so did the disorder.
So would you say our society is experiencing a mental illness epidemic of some kind? Because you include references to many, many, many studies that, taken all together, do kind of make it appear that way.
There's different takes you make on this. So, for example, when the National Comorbidity Study appeared a few years ago in the New York Times, it got big coverage there and so forth. The idea that half of Americans are mentally ill or have been so at one point in time. This was shocking news. because people tended to have a view of mental illness as schizophrenia, psychotic disorders, the more clear-cut, unmistakable instances of mental illness. But there's more to mental illness than just schizophrenia. Mental disorders includes anxiety disorders, substance abuse, mood disorders such as depression and the like. And so part of the amazement or skepticism about the epidemic was that people tend to think of mental disorders as being the extreme cases only. So, for example, if I were to say to you, in tomorrow's New York Times, we'll see headlines that will say 50% of Americans have been physically ill at some time in their life. That's right. They've had a head cold. They've had the flu. They've had headaches. They've had cavities. And, yes, cancer, diabetes, and emphysema as well. The notion that 50% of Americans have been sick at some point in their life is not a very startling finding, because we've all been sick. But once we get to mental disorders, suddenly it's a very shocking notion that half of us have been mentally ill at some point. So part of this is that the scope of mental disorders, even properly construed, is a lot broader than most people think. But even still, there are some concerns that the diagnostic criteria that we use today might be a little bit loose and overly broad and picking up more cases that probably don't really qualify.
We have a question by email from Amanda.
Do you think that examples of multiple personality disorder in entertainment, like the movie Sybil, might have driven the rates of diagnoses?
I think that's very, very likely. That book in the made-for-television movie, immensely popular. And one of the great ironies about the Sybil case is some of the historical scholarship on this case has now revealed that she may never have been a multiple personality to begin with.
Right.
There were audio tape records of the case, and for example, that have surfaced, and some people, I'm calling them historians, so they're sort of amateur historians of psychiatry and so forth, and some professional, were able to identify the original records of the original Sybil and so forth, and it appears as if she may not have actually had all those traumatic experiences that sort of gave us the model of the classic MPD. But certainly this brilliant, artistic, yet traumatized woman who is struggling to make sense of her life and expressed her distress with these many personalities was certainly a very vivid case, no doubt, and provided the classic, iconic figure of the MPD person. So I think that's true, and I think it shows how culture can influence mental disorders in various degrees. This one being a very good example of that.
Well, actually, our next question is from Sterling.
What is your opinion of the view that mental illness is largely based on the expectations of the culture the patient is in?
I think that culture penetrates different mental disorders to differing degree. For example, a classic debate between sort of biological reductionist theorists and social constructionists who tend to believe that all forms of mental disorder are largely shaped by the culture in which people live. But I think there's a more nuanced take on this that seems to capture it. So, for example, there are some mental disorders that appear pretty much the same around the world, and even throughout history. Bipolar disorder, for example, is that way. Schizophrenia appears very much around the world that way. I mean, the content of the delusions may differ. A person suffering from paranoid schizophrenia in the outback of Australia is unlikely to have delusions about the CIA, for example. There'll be other sorts of imagined enemies, for example, stalking the person. And then you have other types of disorders where the culture penetrates a little bit more. So, for example, in panic disorder, people in the West typically, they will respond fearfully to certain often benign bodily sensations, and you have their heart will skip a beat, they feel suddenly dizzy, and they think, oh my goodness, something serious is going on. They get more anxious, which amplifies the symptoms, etc. It spirals into a full-blown panic attack. People in the West worry about their heart and heart attacks and things of that sort. But then you take people from Cambodia who, for example, live in the United States today. My colleague Devin Hinton at Harvard, he's an anthropologist and a psychiatrist, and we've collaborated on studies of panic disorder in Cambodian refugees of the Pol Pot regime who suffered terrible trauma and the like. And they have panic disorder too, but they have entirely different types of reactions. And so they'll have bodily symptoms such as a stiff neck, and they will believe that wind, which is circulating through their bloodstream along with blood, can get blocked. And that if you have wind blockade, you may get a fatal stroke. And so the symptoms they focus on, such as a stiff neck, tend to be different from, say, a skipped heartbeat in the West. And the belief of what might happen, getting wind blockade that leads to a stroke versus a heart attack, tends to differ. So there's some cultural penetration on what these symptoms really mean. But the process of responding fearfully to one's own bodily sensations, setting off this spiraling panic attack, seems to be the same. And then finally you get conditions such as bulimia nervosa, and even more so multiple personality disorder, that seem to be largely products of cultural idioms of distress that shape how people express that distress. So I think it varies across mental disorders, the degree to which culture penetrates the syndrome itself.
You also say that evolutionary psychology could come into play here.
Well, that has been certainly a popular sort of an approach. Jerry Wakefield, who's a clinical social worker and a philosopher of science, has suggested that his harmful dysfunction analysis can provide sort of a clear red line, so to speak, between disorders and distress, where the dysfunction is some psychobiological mechanism of the mind, an adaptation that was the target of natural selection, for example, that has gone awry. So something is not functioning as evolution, quote unquote, designed it to. So this has been a very popular theory. The problem with that, unfortunately, is that we really don't know the natural history of the psychobiological mechanisms of the mind. There's cognition. There are no fossil records for cognition. But evolutionary geneticists have certainly helped us out here a little bit. For example, people have asked the question, if mental disorders are influenced by genes and they're clearly maladaptive, at least the clear-cut cases are, they shorten life, they reduce fertility, and so on and so forth. Why are they around today? And one possibility is that there are many different aberrant alleles that contribute to vulnerability to mental disorder. And as some are removed by selection, new mutations emerge. And so it's a bit of a race going on. And so natural selection never really completely eliminates them. So they sort of linger on in the population. It's still fairly common.
I just have to point out there are full chapters on each of these topics. I suggest you pick up this book because there's going to be far more that we cannot discuss that I would really like to. But at this point, you're listening to Skeptically Speaking, and I'm talking to Richard J. McNally, the author of What is Mental Illness? And we'll be right back after this.
On the next episode of Skeptically Speaking, we'll look at how society and geography affect people's access to healthcare and the quality of care they receive. We're joined by Dr. Sasha McNally, professor at the University of New Brunswick, to discuss her research into the social history of rural medicine and medical practices. And we'll speak to Erin Acharya, project manager at HealthRight International, and Dr. Gary Stadmauer about their work on healthcare and human rights. That's next week on Skeptically Speaking on your local radio station or online at skepticallyspeaking.com.
Welcome back to Skeptically Speaking. I'm your host, Desiree Schell. I'm talking with Richard J. McNally, professor and director of clinical training in the Department of Psychology at Harvard University. Now, you've said in your book that those most in need of mental health treatment don't receive it, whereas those least in need do. Can you explain that?
Those data arose from the National Comorbidity Study Survey Revised, the NCSR. And essentially what happened in the study is that the interviewers asked people whether they sought help for mental disorders or they did not, and also what type of help they sought. And there were a number of different things that appeared from the study. One was that people with very severe mental disorders often were not plugged into the mental health system for one reason or another. And other people who did not qualify for a formal mental disorder, but who nevertheless was experiencing a distress, did seek mental health services. And so, for example, William Narrow, a psychiatric epidemiologist, commented, he says, we have a situation of unmet need where people who are clearly suffering from mental disorders are not seeking help. And then we also have cases of met on need, as he called it, cases of individuals who are plugged into the mental health system, receiving services, but who really don't qualify for a formal mental disorder. Now, but of course, people do seek help from counselors and so forth with problems that don't really qualify for full mental disorder. So we don't necessarily want to deny them services, but it is kind of an interesting mismatch that the people who are most in need often were those least likely to be getting it, and vice versa.
We have a question from Joe.
Why don't people take mental illness as seriously as physical illnesses? I'm not just talking about the public. Many doctors seem to feel that some mental illnesses are all on your head, so to speak.
Yeah, I think that dates back to sort of a dualist conception of our mind, so to speak. That we have the mental world and the physical world, and they are two separate sorts of things. But of course, the mental world is entirely embodied in the brain, and so to say that it's all in one's head, well, yes, it is in the brain, but it's not as if it's in some sort of mysterious space that's unrelated to the physical body. I think that in many cases, when people have been skeptical and not taking mental disorders quite as seriously, it was because a lot of the really obvious sorts of lesions or abnormalities and so forth were not all that evident with the methods at the time. So, for example, some of the brain abnormalities, anatomical abnormalities that are now detectable with neuroimaging in schizophrenia and other mental disorders, now sort of provide the basis, a suggestion of where things might potentially be going wrong with the brain that produces things like hallucinations and so forth. But not that many years ago, those sorts of technologies were unavailable. And so you had someone behaving in unusual ways. People say, well, there must be something wrong with their brain. Or other people say, well, maybe it's all in their head, because there's no physical evidence. And neuroimaging, I think, is to some degree, rightly or wrongly, provided pictures of the brain, its structure, its function, and dysfunction that provide a better basis for saying, look, the mental disorders are embodied in the brain. And they're like physical disorders. I mean, we have disorders of the cardiovascular system, we have disorders of the respiratory system, and we have disorders of the central nervous system. It's just that the latter have been harder to pin down than the former.
So how do you feel about the, at this point, fairly commonly held perception that psychiatry is medicalizing normal emotions, or at least emotions that are within the normal range?
Well, yeah, I think this sort of harkens back to the whole the boundary problem again here, because you've got essentially different groups, so to speak, stakeholders, you might call them, in the whole mental health field that are sort of tugging at this boundary. Some groups want to expand it, some groups want to contract it. Those wanting to expand it are, for example, pharmaceutical companies looking to open up new markets. And so you have advertisements appearing on television for social anxiety disorder. And that where does this differ from shyness? Well, if they broaden it to embrace people who might be a little shy and uncomfortable temperamentally, then maybe we're medicalizing just a normal part of human personality. So they've got a vested interest in doing that. They're opening up new markets. They're in the business of selling more drugs. And other groups, insurance companies, of course, are tugging on the boundary the other way, obviously. But I think ultimately what happens here is that there's no clear-cut natural boundary separating the two. In other words, there are facts about the human mind and the brain that scientists can ascertain, but where we draw the line, say, well, those facts signify disorder, those merely distress, is subject to all these types of negotiations among all of these different parties. And ultimately, I think it comes down to the cost-benefit analysis. mean, should someone take, say, an SSRI for anxiety, shyness? What are the costs? What are the benefits? And people are going to make those sorts of decisions. This has also happened with cholesterol-lowering drugs. To the extent that the costs of these things are not all that great, people are more inclined to tilt in that direction. To the extent that medications have drawbacks, people are going to be less likely.
There are many questions that are coming in, people like you. From the website, Kelly.
How can future scientific research address the boundary problem, specifically in the context of anxiety disorders?
I think the way it can address it is not try to solve the problem and say, well, this is mere worry and this is generalized anxiety disorder. What it can do is can enrich our understanding about how the mind and how the brain works along the dimension of worry and anxiety, and to what extent these things, where it differs. So there's facts about the brain, facts about the mind that scientists can clarify. And those facts then provide the basis for arguments of where we ought to draw these boundaries. So, for example, if you had someone, this is just a hypothetical case, where you have two different anxious individuals, and some individuals are characterized by all sorts of deviations on various measures of brain function, et cetera, and anxiety and social impairment, et cetera, and other people may not be characterized by these sorts of deviations. Well, then the fact of the matter about where they vary on various different brain functions can play a role in helping adjudicate where we might sort of draw that line. But in many cases, the issue, it's not really about the science per se, but about impairment. So, for example, people who may be temperamentally shy, but they really don't want to become the life of the party, or they don't want to become a salesman. And so they're not really impaired. They may have exactly the same sort of brain as somebody else who wants to become a teacher or an entertainer or whatever. And so you have exactly the same brain, but you have people whose social environments differ. In one case, they have real impairment. It's really getting in the way. In the other case, it's not. Those are not matters for the scientists to decide.
And a question from Stuart.
Have there been instances of a pharmaceutical company driving a particular diagnosis, either the recognition or treatment, so as to market a particular product?
Well, it's interesting. There seems to be little evidence that the pharmaceutical companies had much of anything to do with the DSM-3, the original diagnostic revolution that provided the very explicit criteria that fostered the research, et cetera. But they have since caught up, so to speak. And so a lot of the companies were very interested in sponsoring, say, symposia at conferences to try to increase awareness of, say, social anxiety disorder, or other sorts of conditions. That's not necessarily bad in any way, but it may distort, for example, the types of treatments that are available for these conditions. Well, let's take obsessive compulsive disorder, another one that has gotten a lot of attention from pharmaceutical companies. Still the best treatments for OCD are behavioral and cognitive behavioral treatments. There are some effective pharmacologic ones, but they tend not to be quite as good. And so you have cases where raising awareness of OCD in our society, it's a condition that incidentally was one that caused a lot of shame for people, and they didn't seek treatment, and it's far more common than anybody had ever imagined, say 25, 30 years ago. But the pharmaceutical raising of awareness, which in itself is not a problem, they're of course selling a certain type of product, and the behavioral interventions that have been so effective, they don't have that sort of a marketing angle, and so there have been cases like this.
Now, those last couple of points, those things don't exactly contribute positively to the public impression of psychiatry. So, are things as problematic as they seem? Well,
that the real I think issues here have been with scholars such as psychologists such as Irving Kirsch and others who've examined some of the the clinical trials that have been submitted to the FDA for consideration in terms of approving medications for a certain condition, say for a new drug for social anxiety disorder, a new drug for OCD or depression or what have you. You have to have 2 of these randomized controlled trials that show that it outperforms the pill placebo and so forth. And those are the ones that get published, right? The problem is that there are a lot of trials that are so-called failed trials where the drug really doesn't outperform the pill placebo. And Kirsch and some other scholars have gotten a hold of those data. The Freedom of Information Act, I think, had some role in this or whatever. And then you find out that these drugs are not all that effective for a lot of these conditions. When you look at the entire unpublished as well as published database. And this has been quite a shock for most of us because what happens, of course, is that doctors don't prescribe placebos. They prescribe medications, and people have side effects from them, etc., and people do get better. But what Kirsch was arguing is that a lot of these placebos were just as effective. But those studies weren't published. And so that has, I think, been the real issue, not so much the marketing of the medications, but whether or not they're actually as efficacious as we have often believed. Now, I'm not talking about all of the medications. I'm really referring here to largely the SSRI groups that have been the target of some of these recent scholarly scrutiny.
And I'm going to give Darren the last question.
What impact do you think the anti-psychiatry movement, the recent CHR YouTube campaign, for example, is having on the mental health field? How can we reach those who have come to believe that mental health professionals are not looking out for the patient's well-being?
Yeah, the anti-psychiatry movement, David Cooper and R.D. Lang and people who are not really anti-psychiatrists, such as Thomas Szasz, who questioned whether or not these are real medical conditions to begin with. I think that their influence has not been all that great. Mm-hmm. Quite frankly, certainly Szasz was very effective in dealing with questions of involuntary commitment and raising awareness of that. But the notion that schizophrenia was simply a myth, nobody, I think, really takes that very seriously today. And so the anti-psychiatry movement, doesn't have the profile that it did, say, in the early 70s. And so I don't think they're having that much of an effect. I mean, the concerns about the pharmaceutical companies supporting symposia at conferences and sort of coloring the scientific culture of what the doctors encounter, or the work of Kirsch and others who have examined the unpublished trials and saying, gosh, these things aren't quite as effective as we all thought. Those sorts of findings, but they're from within the field of psychology and psychiatry, as opposed to people from the outside attacking the field. So I think it's really been from within that these concerns have arisen, the more compelling ones, rather than that mental illnesses are nothing but social construction, it's a myth, et cetera, et cetera. That was part of the anti-psychiatry movement.
I have so many more questions, and the audience has so many more questions, but we are out of time. Thanks very much for being here, Richard.
Thank you.
You can find Richard J. McNally at McNallyLab.com or at the link on our site at skepticallyspeaking.com. From there, click the links to Facebook, to Twitter, or to iTunes, where you can listen to past episodes, subscribe to the show, or leave a review. Thanks for listening, and we'll see you next week on Skeptically Speaking.
Bring it on, the skeptics await your letter. Your call, tweet, homing, pigeon, whatever. Desiree Shell, gonna raise a little hell, break the spell of Pavlov's spells. Cause we're skeptically speaking, our mind reading tarot cards and witches, psychics, and their spoon-bending mind tricks. All the humbug, flim-flam, frauds and shams, the charlatan who I don't think you understand. It's the hocus pocus, out of focus locus, eroding the brain, making gains on the hopeless. Let the crystal ball fall, smash on the floor, leave the pieces alone, we don't need them anymore. Just a microscope, telescope, magnifier, reading in between the lines of these lies. Bring it on, the skeptics await your letter. Your call, tweet, homing, pigeon, whatever. Desiree Shell, gonna raise a little hell, metaphorically that is, cause we're skeptically speaking.
Skeptically Speaking is produced with the support of CJSR 88.5 FM in Edmonton, Alberta, Canada. Our studio assistants are Brent Kelly and Rochelle Saunders. Ryan Bromsgrove is our studio technician and research assistant. The show is produced and edited by K.O. Myers. Our theme song was written and recorded by A.O.K. And I'm your host, Desiree Schell.